Hello everyone, I am back, and this time it is my pleasure to introduce Professor Jervoise Andreyev, who is a consultant gastroenterologist at Lincolnshire Hospitals, and he was the first gastroenterologist appointed worldwide specifically to treat the GI side effects of cancer treatments. Over the last 17 years, the research he has produced significant amounts of clinically focused evidence which have redefined the scale of the problems caused by the consequences of cancer therapies, why they happen, and how to look after these patients best. Take it away.
Thanks very much. Can I have my slides, please? So I was asked today to talk about research into pelvic radiation disease. I'm a gastroenterologist, so my focus is on the GI tract. But I think some of the things I have to say related to gastroenterology are relevant for everyone dealing with this issue. So it was in 2010 when we defined pelvic radiation disease. And at that time, I think people working in the field felt that people who got side effects of radiation were receiving very fragmented care. Nobody felt that the side effects were really their business, and very few people were concerned about looking after people in a holistic way. So the concept of defining a new condition, pelvic radiation disease, was to try and get people to take it much more seriously. Next slide, please. These are data from last week from Pubmed, and what you can see is that somebody used this term pelvic radiation disease in 1992. It wasn't used in a very holistic way at that time, and then from 2010 to now, there have been 38 citations, and this is looking for papers which either mention pelvic radiation disease in their title or in the abstract. Next slide, please. And in that time, 2 papers, and those were our papers, defined the condition. It's always been a problem because so many people are involved in the field. The oncologists, I'm a gastroenterologist. If people have urological problems, they need some sort of urological expertise, gynecological problems. And so it's very difficult to know how to speak to it. But back then, to define the condition, we wrote an opinion piece in the Lancet Oncology and also in a gastroenterology journal. Slightly disappointingly, looking at these 38 citations, almost half have come from my research team. And when you break them down into what they were about, 24 of these citations were just general reviews of the topic, and some were quite good and some were less good in my view, but they weren't producing anything original. And of the original studies, 7 were human interventional studies, and that's what I'm interested in because there's so many affected humans. There were 4 animal intervention studies and 1 very basic cellular study. In the same time, if you looked up something like ischemic heart disease, for example, you would find over 100,000 citations. So next, please. So really defining this terminology, pelvic radiation disease, so far has not changed the goalpost. It's not changed where we are. It's not changed how people think about it. And one of the reasons to use this terminology is that it's holistic. But the second thing is that a lot of the other terminology used for radiation damage is not correct. And because it's not correct, it encourages people, and especially clinicians, to think about the conditions in the wrong way. So as a charity, I think that PRDA really need to focus, and this is something that a charity can do, is to get this terminology much more widely adopted, and both at a scientific level, so by getting getting mesh term accepted, but also get it out much more widely into the general population. Next, please. So pelvic radiation disease, as it per se, hasn't generated a huge amount of interest. Another way to look at research is to go to one of the registers where clinical research is registered, and once it's being registered there, it won't necessarily happen, but most studies get registered because if they're not registered, they can't be published. And if you look for words which are associated with damage after radiotherapy, there is a minimal amount of research activity going on. There are 2 studies from China, and the Chinese have got a huge problem. They have a huge problem with cancer, and they have vast numbers of patients who are having radiotherapy who are in terrible trouble as a result of the radiotherapy with what I would call pelvic radiation disease. Some of the treatments they're using, I think we wouldn't use in this country. They're interesting, they're very different approaches, but I think they are somewhat blunderbuss in their approach. So the first 2 studies that I could find on clinicaltrials.gov, there was a very small study, a phase 1 study, so it's really a very basic study, say, is this even safe to use in human beings of a radioprotectant? And most of the radioprotectants that have been studied have never come into widespread clinical practice. And there's a second study which is looking at how to treat people with bleeding from the gut as a result of radiotherapy. And again, I think in my career, I have never needed to do this, but the Chinese have recently published a study suggesting this is a useful, though somewhat mutilating approach. And they're going on to study this further. There's a small study about fecal transplantation and the use of this technique for people with established damage. There's a planned trial which hasn't started using thalidomide for people with difficult bleeding, and there's a huge rationale for using this drug. It's got a very bad reputation, but actually it's a very interesting drug. We were talking about trying it in 2003 or 2004 in the UK. The study never got off the ground because there was too much opposition. And so over 18 years, people are still talking about it, and it hasn't started. And there's one very big European trial which is planned, and it was planned before COVID started, so I don't know what has happened about using this substance also to treat bleeding. But if you think about how many people are affected by radiation damage, how many people have long-term problems, it's incredibly disappointing that there is so little planned ongoing research in this area. Next, please. So when you think about research questions, I'm sure there are many which will come to mind for you. As a gastroenterologist, these are the main questions that I think are important. And I'm just going to run through them quickly. Who's at risk? Why does pelvic radiation disease happen? How common is it? What can you do to prevent it? What can you do to diagnose it? How do you treat it? And conceptually, something which is incredibly important in gastroenterology and is the mainstay of treatment for inflammatory bowel disease, a condition which takes up a lot of gastroenterology time, but affects only a very small proportion of the population, but dominates conferences, is how do you not only treat the symptoms, but how do you reverse the process, the disease process, to make people healthy again? And I think pelvic radiation disease, this is really the key. Next slide, please. So who's at risk of pelvic radiation disease? This is a table which was published in a journal in 2012 by Lorenzo Fuccio. I think the same table could have been published 30 years ago, and the table could be published again today with very little changes. There's one change, and I'll come back to that in a minute. However, next, please. the problem with these risk factors is it's impossible to quantify for an individual how much they are at risk of running into serious trouble. So if you're diagnosed with cancer, people can tell you if you have this treatment, you have this percentage chance of responding, you have this percentage chance of not responding, and this is your percentage risk of being alive or dead, and these in a year or 5 years. Nobody has done those studies, and nobody seems to be interested in doing those studies to determine how much individual risk there is for patients. Next, please. The one thing that's missing and has been a major advance, I think, in our understanding from that previous table is the importance of the microbiota, the germs that live in the bowel. And they seem, and there's this very nice study which is about to be published, it's not out yet, by Miguel Ferreira and his group at Imperial, which suggests that really some germs in the bowel are very important to predisposing to radiation damage, which kind of raises the option that could we do something about this before the radiotherapy started. And Miguel's study, which is the largest in the literature to date, well, once it's published it will be, follows on from a lot of other much smaller studies which suggest that there could be potential problems. Next, please. So the next area of research is why and how does radiation damage happen? Why does pelvic radiation disease occur? And we understand that where the radiotherapy is concentrated, it kills, but further out what it does is it damages blood vessels, and as a result of that, you get thickening of the tissues. And in the gut, the thickening of the tissues destroys the ability of the gut to do the things it is supposed to do to work well. Its physiology, it destroys its physiological reserve. And as a result of that destruction of the physiological reserve, people develop symptoms. In the long term, it also increases the risk of second malignancy. Next. However, what the research hasn't answered is why does not everyone who has the radiotherapy develop the same problems? And maybe the risk factors that I talked about on the previous slide are important, but we also really don't know what is going on at a molecular level in humans. Nearly all the data are from animal studies, and all the animal research is using models which may not be relevant to humans. So there needs to be a huge refocusing of the effort to try and confirm whether the things that we can see happening in animals, which are very imperfect models, are actually the same as human. And perhaps one of the most important things, and the COVID pandemic has shown us this, is the immune system may be very important in driving some of this change. And there is not a single study of what is going on with the immune systems of people in the gut who have had radiotherapy. Next, please. So how common is the problem? Well, I think it's very common. Next. Possibly when modern techniques are used, it's a little bit less common, but the data aren't there to support that. So that's what the oncologists will tell you. The problem is, how do you measure? How do you define that pelvic radiation disease is there? Because what we have to do at the moment is rely on symptoms. But there will be a group of people with pelvic radiation disease who have no symptoms, who have no problems until something catastrophic happens 2 years or 5 years or 20 years later. And probably what is the important thing is what's going on at the molecular level. And we do not have the biomarkers available to measure it. So this is a big research problem, because you can say this number of people will seem to develop problems after radiotherapy, and it's somewhere between 1 in 5 and 1 in 2 people depending what sort of tumor they have and where it is and how it's treated. But that may not be correct, and that may not be the number of people who are suffering from pelvic radiation disease 20 years on. Next, please. So what can you do to prevent pelvic radiation disease? Well, research here has been very interesting. Next, please. Because what it tells us is that the fundamentally important thing is something called the consequential effect. Next, please. So the person who gets a severe problem during radiotherapy is much more likely to develop long-term effects. Probably, if we could measure what was going on a molecular level, we could assess this even more accurately. Next, please. But this consequential effect, this risk of long-term severe toxicity, is completely independent of the radiotherapy dose. So there are data out there and some studies now which suggest that by the time a person is halfway through the radiotherapy, you should be able to predict whether there's someone who are going to get into very long-term trouble, which means that you should be able to intervene at a very early stage, either during or after. An intervention to prevent the severe acute response up to now has focused just on changing the radiotherapy dose. Next slide, please. More important, so this is a fantastic study which was published recently in the BMJ Open. And I think it's fantastic for several reasons. The worst thing about this study is that it's published in this journal. And I was asked to referee this paper when it went initially to a gastroenterology journal. I was the only expert reviewer. And I wrote a review to say this was one of the most important advances. This paper was one of the most important advances in our understanding of how to manage patients with radiation damage that had been published for many years. And I was overruled by the editorial board, who said that they didn't think their readers would be interested in it, which I think is disastrous. Why do they ask an expert reviewer to read a paper like this and then not pay any attention to what he said? But this is a very interesting study because this is a group of gastroenterologists and oncologists working together. Next, please. And what they did was they intervened in patients being treated for cervical or bladder cancer when they developed symptoms. And to do this is difficult because this is quite a short course of treatment, 5 weeks. And in those patients, they looked for what are seen to be problems that arise which might make damage worse. The development of bacterial overgrowth, they looked for lactose intolerance, and they looked for a condition called bile acid absorption. They found it at levels that have been described before, and they intervened in these patients with treatment to try and reduce these problems. Next slide. And what they showed is if you intervene in this patient group and deal with the problems during radiotherapy, that actually at a year, they have a better quality of life. So this is a fantastic study because actually it shows that just adjusting the radiation dose doesn't really make very much difference. But if you intervene to deal with the causes of the side effects, then people will get better. Next, please. So the next research question is, how do you diagnose it? Can you do it by symptoms? And I've told you that's a problem. You can't do it using the normal things that doctors would use with devices or what it looks like with X-ray. What about biomarkers? Unfortunately, no data. Next slide. So how do you treat it? Well, this is one area where we know what to do with symptoms. What we know is from lots and lots of different studies from different institutions that if you adopt a very systematic way to treating patients, they will respond and you can make them better. Next slide. But it's not just about symptoms. One of the problems that patients struggle with sometimes is bleeding throughout after prostate radiotherapy. So 1 in 20 patients will have difficult bleeding. And the treatments are very poor for this. They're very difficult with big risk of side effects. This very interesting treatment, radiofrequency ablation, has been talked about in this context for 10 years. And yet this systematic review published 18 months ago showed that only minuscule data are available on this patient group. That we really don't know, even after 10 years with a common problem after radiotherapy, whether this treatment is safe or helpful. Next slide. The final area which I think is interesting in terms of research is, can you change what's going on in the tissues to revert back to a pre-radiotherapy state? Hyperbaric oxygen therapy is very interesting. One trial from America in 2008 suggested it was very helpful. Our trial, which we did in London and around the UK, 2015, showed it didn't help. 2 trials. That's all there is. And we don't know the answer, and no new ongoing trials. Next slide, please. Very interesting combination of a non-toxic treatment, vitamin E with pentoxifillin. Lots and lots of studies, some of them positive, some of them negative. Pentoxifillin and vitamin E have not become mainstream, and when you use them as a clinician, some patients respond and some don't. Next slide, please. This is a trial which we have just submitted for publication, where we used something which is akin to vitamin E with pentoxifillin, something called gamma-tocopherols. Animal data suggests this is much more effective. We randomized 62 patients in this study. 40 got this treatment, 22 got placebo. They were quite a long time after radiotherapy and with difficult symptoms. They all took medication, but perhaps our study shows why this medication doesn't work, because in 40% of patients, despite them taking their medication, we know they were taking their medication, we could not detect acceptable levels of the medication in their blood, which suggests that in people with very damaged guts, perhaps the things that we would use normally and we would expect to work don't work. And this is the first study out of about 20 or 30 studies in the literature which actually asked why might these things not be working. And our study showed no improvement in symptom scores or quality of life, which is hardly surprising because 4 out of 10 patients weren't getting enough of the drug into their system. So my final slide, please. I think of it. Is there another one? Okay, so my final slide isn't showing there, but what it says is that there's a big problem, that pelvic radiation disease has not become a mainstream issue yet. Despite talking about it, despite a lot of effort, it isn't important to people who deal with these patients. They're small, all the studies that are done are small. Many of the studies are done are not multidisciplinary, which gives them big problems, but the groundwork is there. So if you're thinking about research in pelvic radiation disease and you're a young person who wants to do research, I think you're in a fantastic position because the groundwork's there, the building blocks are there, but there's so much basic stuff which still needs to be done. Thank you very much.
Thank you very, very much for that, Professor. That was very interesting. I would just like to say that Anne will actually detailing more about our plans to help raise awareness this afternoon. So we've got a few questions. Firstly, do you think we need high-profile national leadership in order to raise awareness and drive research, or do you think it's better for small groups to drive the agenda?
Well, I think anything that can raise the profile is important. I have never heard on Woman's Hour, and I'm an avid listener of Woman's Hour, I have never heard a program about the consequences of cervical cancer treatment. I've had loads and loads and loads and loads about how diagnosis and, about difficulties with smears, but there's nothing about the consequences of treatment. Nobody knows about this, but I think something has changed. I think long COVID is actually, for pelvic radiation disease, is a blessing, because for the first time, really, I think there's been a rise in the national consciousness level that actually you don't just get diagnosed with a condition, get some treatment, and then it's finished. But that sometimes things go on and on. So I think we just need to talk about it at every level. And every Daily Mail piece in the last 15 years has been about sensationalism. It's about this patient has been burnt by a radiotherapy machine and how evil it is. And that's not the issue. These are thousands and thousands of people worldwide, and there are much bigger problems in Africa and China and India than we've ever had here. And something has to change, because these people aren't dying anymore. They're cured of their cancer and they're living for a long time. So we really need to raise the level. We need needs to be higher at a professional level, a consciousness level. But the fact that when a good gastroenterology journal turned down a major advance in a field by saying their readership won't be interested, just shows how much more work we have to do.
Thank you. And just one last question. What do you think the symptom burden in survivors of childhood cancers are once they're adults?
I think that's a very interesting question, and there aren't a lot of data. The pediatricians say that it's not a very big issue. And in my practice, I've seen very few people treated in childhood who are struggling with long-term symptoms. So whether in childhood there are repair mechanisms which go on, which adults don't have. The one issue I am very concerned about, and we're just finishing a systematic review looking at this, and is the risk of second malignancy. And people who've had previous radiotherapy are not offered at the moment. They're not considered a high-risk group for screening. And I think this is wrong for bowel cancer, and I think that should change. But I think there are very few data about the pediatric group and what happens.
Amazing. Thank you very, very much for kicking off the afternoon so well.